Hello, PsychU community, and welcome to today's webinar, Optimizing Clinical and Mental Health Provider Performance. Thank you for joining us today. I am Brian Dickinson, a consultant for Open Minds. I'll be serving as the moderator and presenter for today's exciting discussion featuring Dr. Greg Downing and Rebecca Plonsky.
So let's talk about performance metrics and their implementation. So we referenced the PHQ. This again is widely adopted both in primary care and multiple behavioral health settings. But one thing to consider is the adoption and the administration is not enough to really understand if we're moving the needle on symptom remediation related to depressive symptoms. So really wanting to take a step further. So once an individual screens positive for depression, are we tracking whether or not those interventions have made an impact? So for instance, if that individual screens positive, has an SSRI been onboarded? Have those prescriptions been filled at the intervals that were clinically indicated? Were they engaged in at least brief therapy that's either CBT driven or evidence-based? And those are brief sessions that could be between 15 and 18 minutes. And what has happened over the course of 3 to 6 months working with that individual for symptom remediation. So again, just strongly encouraging that the administration of this is not enough, that we're really looking at this holistically about how we are impacting, driving down the depression symptoms. I'm going to hand it back to Dr. Downing to speak more further.
Hey, thanks, Rebecca. That's been very helpful here. And one sort of nugget that I've sort of encouraged people to think about in this context is looking at these measures as in the context of another vital sign, that you fit into the routines in which your sort of style and flow of engaging patients may be. And some aspects of this will be done before they get to your waiting room or as they're getting into their waiting room and checking in, or others more sensitive settings might be within the exam rooms themselves. So the other caveat is that there's so much to be learned from peer-to-peer interactions on this, and we look forward to forums in which people who are really optimizing the measures in their own practice for different subsets of patients, those kinds of best practices will, I think, help raise the level across the community. I wanted to mention a couple new standard areas that are relevant to this in terms of behavioral health care standards, and the Joint Commission and TJC has just recently published 3 elements of performance at the hospital level. And the first one requires organizations to use a standard tool or instrument to monitor an individual's progress. The second is requiring organizations to analyze the data generated by this activity and use the results to inform individuals' goals and objectives as needed. And earlier, Rebecca mentioned the aspect of using huddles or other administrative meetings that you have to sort of just integrate the data reports at a time, quarterly or monthly level within groups, so that they can actually see the value of the information being pulled together and learn from others in the provider groups how they're using the data to gauge their treatment or identifying subsets of populations in their practice to think about different approaches to interventions. And then the last is requiring organizations to use their data to evaluate outcomes of treatment or services provided to the populations that they serve more broadly and generally. And this is a long ways to go in terms of integrating this within communities, but this is a start. So this is another sort of higher level perspective that just wanted to kind of go through again, that to be patient-centric, clinicians should choose really a brief diagnostic specific rating scale or global functioning scale that best informs the decisions for each patient, and incorporates a suite of scales into the electronic health records to integrate into the clinician's workflows. As I talk to different practice groups, they're using a lot of different tools or ways in which to have the patient do this, in some cases still by paper, but in many cases it's either through the EHRs increasingly as a common reporting function that they're doing through their exam or interactions with the patient. A discussion of the recovery goals should be part of every clinical encounter, in addition to the structured assessment of symptom severity. Sometimes it's just important for us to remind the patients of saying, well, here's our target, here's what we're really trying to get to, and then show them back the results of saying, well, here's where we've come with this particular approach. And that changes to treatment plans can be based on either a lack of the attainment of that goal, or the goals can change, or that the symptoms that were initially the ones that are being approached by this particular modality have not abated. And so measurement-based care could also be used as to assess other important domains such as patient satisfaction, therapeutic alliance, side effects, and functioning. And the aspect of this in terms of its intentions don't always have to be identified at the point at which the data are being collected, but can be useful downstream in being able to do retrospective analysis and looking at effects with medication changes and looking longitudinally for patients' patterns and what might be provoking recurrence.
Okay, thank you, Dr. Downing. This is Rebecca again, and speaking about Lever 3, Sophisticated Reporting and Analytics System. So a recommendation here, if you're not already having one, is to develop a clinical scorecard. This allows to track both team and provider performance. It allows to hold providers and the management team accountable for being able to look at the measures that are being rolled out in the organization. So for instance, when you're looking at productivity related to both clinician, nursing, and prescriber time, often the stories that are told are that those individuals are booked solid in an outpatient setting. But to really be able to dive into that deeper, to look at what the actual no-show rates are. So I've seen in multiple points in my career that although it appears that those providers are productive, when you really look at the data points, there are multiple reschedules that day, and that the no-show rates are really trending upwards of 30% and really should be trended down to 10%. Being able to review that the documentation that's in the electronic health record, or if some of you are still on paper-based records, are directly matched to the billing and coding that's sent out for reimbursement. And also that providers are taking a proactive role if your organization is rendering higher levels of care, whether it's hospital-based or intensive outpatient or partial, where denials can be rendered, that they're taking a proactive role in understanding that this is lost revenue for the organization for services that are rendered. And also being able to take that population health perspective again. So having that 360 review. So when we had referenced a while back our partnerships with payers. So looking at holistically impacts to rendering medication-assisted therapy or mobile treatment, being able to look at treatment programs that are directly linked to avoidable ER visits, particularly in the aging population. Or another example is if we are rolling out an innovative program, for instance, say a crisis stabilization unit that's operating at the third of the cost of an inpatient mental health setting, that we've told a story that there are direct links to a decrease in total cost of care and better health outcomes. And then you can see here on the right of this slide some examples of some key performance indicators that you may want to consider if you haven't adopted already. So for organizations that are dealing with high-risk individuals, so if an organization treats many individuals with, for instance, serious persistent mental illness or serious mental illness, that 100% of those individuals are screened for suicide risk, and that there's active safety planning routinely reviewed with that individual and the treatment team. If an organization is moving towards the rollout of SBIRT, that the organization is tracking the total number of providers that are actively participating and are advancing the use of SBIRT. We had talked a little while ago about the HEDIS measure related to follow-up after mental health hospitalization. So although that guidance says that individuals should be seen within 7 days, we know with high-risk individuals that oftentimes if we wait that long, they're lost to follow-up and may have relapsed. So here it would be for those individuals that are at risk that at least 90% of those identified individuals are not seen within 7 days, but really the recommendation here is within 1 to 3 business days post-discharge from a higher level of care. And then this is a tough story to tell for many organizations, but again, talking about and identifying how your organization's interventions are driving down total medical expense. And lastly, again, if we're thinking about certain specialty populations, serious persistent mental illness, again, we know that employment is a huge direct indicator to better health outcomes and community tenure. So being able to track engagement and rates for employment across that population, and those include both transitional, supportive, and independent employment. And I'm going to hand it back over to Dr. Downing to talk about lever 4.
Hey, thanks, Rebecca. Just one thing that came to mind while you were focusing on these practice level considerations, and one of the things that I've noticed over the years is that within clinics and groups that work together, there often is a person who has much more sort of quantitative perspective on the practice or other elements of business activities within the practice. And one of the things is that it may not be obvious at the outset as who is the best one or people in your team that are quantitatively oriented, that have a handle on numbers and can present them and make them useful. So it's key to, I think, at the beginning, recognize that collecting the data isn't necessarily the goal here, but making good, insightful and insights from it are where we're trying to go. So there may be those that are really good at Tableau or Google Analytics and things that are able to create some simple graphs or perspectives that will show, here's how we're doing in general. Obviously, not individually selecting out specific patients for presentations overall, but giving examples and highlighting, well, where can we use the data better in terms of our own understanding of what's happening in our practice or with our patients. So just wanted to mention that in going along. And so we need to build coaches and team members that will help others in terms of being able to appreciate what the value of that information will be. Rebecca also mentioned earlier, our partnerships along this evaluation method and uses of measures with insurers and other government organizations is important. And then again, we're trying to use numbers in these measures to reach common understanding of clinical scenarios and practice issues. And so I think looking at some examples of how broader organization influences in practice make uses of practice level or patient level data in some ways. And I just wanted to mention 3 of these, and I've provided the citations for them for you to go to their websites and learn more about how they've actually done this. And many of you may be participating in these, and so hats off to you for your hard work and making this known to others. And the DIAMOND study is a depression improvement across Minnesota, offering a new direction, the DIAMOND program. And it's an implemented measurement-based care to help benchmark quality improvement efforts as part of a bundled payment method for depression care management. And there's been another group of Medicaid ACOs that have been working together that include at least one behavioral health quality metric tied to shared savings arrangements. And we've seen good results from that in the reporting out of Illinois, Maine, Minnesota, New Jersey, Oregon, and Vermont working together on that particular bundle. And I wanted to also point out an innovation model from the state of Colorado. And the goal here is this particular program allows 80% of their state residents to access behavioral health services through a measurement-based behavioral integration model across payers. Now, it's relatively early to tell, and it's likely these plans and models for integrating data into payment programs and reporting on them will continue to evolve. We've seen this through CMS and other forms of CMMI. Some of you may know that there's a call out right now for comprehensive joint replacement models. The bundles that have been used for those programs for over 5 years now are going through another iteration and design. So on a big scale in payment, this iterative design and improvement in the methods of using alternative value-based care methods is continuing to evolve. But the good news is that there are innovators in the community that are taking good opportunities here to use the payment system as a lever for change and focusing really on those hard patients, the ones that have complex needs and integration of services. These are the places where a lot of the innovation are occurring. So I want to talk a little bit about the opportunities and challenges for measurement-based care. So to be practical, we're just going to address some of the challenges that lie ahead, and that psychiatric diagnoses are evolving, and the way that we feed information and understand behavior and the influences of communities and stresses of many different types is a rapidly evolving science. We don't have precise biomarkers that can tell us in a blood test or anything close to that in imaging that could really give us a more precise molecular level parameter of measuring behavior. That may come in the future, but we're not there. And the ability to look at precision medicine, of being able to identify specific patient characteristics and making a therapeutic selection, that as the science evolves, that we may have fundamentally different ways in which we go about diagnostic assessment and treatment in the future. And so the uncertain relationships that exist now between diagnosis, treatment, and outcomes, and the limitations associated with the approaches of, in some cases, using randomized trial data to affect our treatment plans, underscores the importance of identifying effective measures. And it's important to have a scientific basis and psychological understanding of what the measures are assessing. So in the absence of this science at this point, our initial treatment choices are often ineffective in making it critical to closely monitor treatment, and particularly in cases where the patient's not perceiving the desired response, that guiding that decision-making process over time can be effective through the uses of measurement-based care.